to our next speaker, Dr. Boer.
Thanks, Matt. Really a privilege to be the second half of the Diabetes Power Hour after Christine. That was a fabulous talk. And Leah, I also want to know the answer to your question. We don't usually biopsy those people, so I think that's something KPMP will address. And also, we've just had some news that NIH is likely to fund a new 2-site biopsy cohort of people with type 1 diabetes that will enroll those sorts of people. So it's focused on type 1 diabetes, but pretty soon, hopefully, we can learn about that phenotype in that demographic. All right, so I'm going to give largely a clinical talk today on GLP-1 receptor agonists. And I do have disclosures, but I haven't worked with any companies that, to my knowledge, make GLP-1 receptor agonists. And these are the KDIGO 2020 diabetes and CKD guidelines. And I think most of us are quite familiar with the metformin dosing for people with type 2 diabetes and chronic kidney disease by eGFR for safety and lactic acidosis. I think most of us are getting much more comfortable with SGLT2 inhibitors, at least in type 2 diabetes. These are now standard of care and probably will expand to other kidney diseases as well. I do think that most of us leave further anti-glycemic therapy largely to endocrinologists and primary care doctors, though increasingly I'm starting to do more of this in my own practice. And that's really what's motivated me to focus on this today. I've learned more about GLP-1 receptor agonists through working on these guidelines and increasingly through clinical care. And I'm not managing glycemia for most of my patients with stage 3 CKD and type 2 diabetes, for example, but finding that the more complex cases, like our transplant and dialysis patients who look to us for a lot of their care, I am starting to do more. And so I'm going to give 2 quick cases here. People from my clinic at the VA who, both of whom I recently started on a GLP-1 receptor agonist. For better or worse, and you can decide at the end which of those it might be. So the first case is a 51-year-old man with kidney failure due to lupus nephritis. He had a living-related kidney transplant from his sister 10 years ago, and then 8 years ago developed what was then called new onset diabetes after transplantation. Initially diet controlled, keeping his hemoglobin A1C under control, but a couple of years ago it went up to 9.2%. He started metformin and then glimepiride. Some people on this call will recognize him perhaps. He was recently admitted 2 months ago for new heart failure, which we don't know whether it's due to diastolic dysfunction or constriction. He had a normal EF. He's discharged, of course, now and doing well. He's on usual immunosuppression with tacrolimus, mycophenolate, and prednisone, blood pressure control, et cetera, the metformin and glimepiride. He's a big guy, both tall and heavy, with a BMI of 34 kilograms per meter squared, normal EGFR, and his hemoglobin A1C was 8.9%. So he was in my clinic. He was worried about his hemoglobin A1C and considered a GLP-1 for him. The second patient that I will illustrate is a 48-year-old man with kidney failure from type 2 diabetes, started early last year on peritoneal dialysis. He had HFrEF as well, though with volume management his EF has improved, typical complications. His diabetes therapy is only a single injection of glargine per day, 40 units QHS. That had gone up after starting peritoneal dialysis, and his glucose control shown by his self-monitored blood glucose, he's pretty conscientious about this, had worsened, even though this fairly meaningless hemoglobin A1C was normal. He's also a big guy with a BMI of 37. So I'll come back to these patients and we can talk about them and their suitability or not for GLP-1 receptor agonists. I want to just very briefly give some background on the incretin system. Most of us are familiar with this. So incretins are, there are a number of them. The 2 most important incretin hormones are GIP, which is glucose-dependent insulinotropic polypeptide, and glucagon-like peptide 1 or GLP-1. They're secreted by intestinal cells. They act primarily on the pancreas to encourage and augment insulin secretion when the pancreas senses glucose. And they're degraded by dipeptidyl peptidase 4, DPP4, into degradation products. So here's a little more detail on that process. It's actually very, very interesting. And I think one of the big scientific advances over the last 20 or so years is the characterization of this system and its therapeutic use. And these GLP-1 comes from this pro-hormone, pro-glucagon. It's the same pro-hormone that's produced in pancreatic alpha cells and cleaved to glucagon, but in enteroendocrine L cells, it's cleaved by PCSK1 and PCSK3 to GLP-1. And here's another picture of the L cell. These line the GI tract. They become increasingly abundant as you go down and are very abundant in the ileum. And when they sense nutrients of all sorts, they secrete GLP-1 into the portal circulation. Here is there are two forms. On the lower right here is a picture. There are either 30 or 31 amino acid forms, small peptides. They have a half-life of about 2 minutes because DPP4, which is present in the circulation and tethered to cells, rapidly cleaves off these last two peptides to inactivate it. It's not renally cleared, it's cleared by enzymatic degradation. When it does bind to its receptor and target cells, it activates intercellular G-coupled protein related pathways to affect biologic actions. And it has a lot of biologic actions. So the main ones are in the pancreas, as I noted, increases glucose-induced insulin secretion. It actually also acts on delta cells in the pancreas to increase somatostatin, which then acts on alpha cells. And there are also direct actions on alpha cells to suppress glucagon. And importantly, it also has effects on beta cells, not just to increase insulin secretion, but to promote growth and inhibit apoptosis. So thought to help preserve beta cells in the process of progressive type 2 diabetes. And the GRADE trial, which was shown at the ADA sessions last June, showed that, it hasn't been published yet, but showed that compared to other drugs, GLP-1 receptor agonists were more durable. They resulted in longer lasting control of type 2 diabetes. The other main effects are on the GI tract. So it delays gastric emptying, called the ileal brake. This can cause some satiety and nausea and vomiting, and it works on the central nervous system to reduce satiety, which is probably the main mechanism of weight loss. And it increases cardiac output, has some direct effects on the myocardium and endothelium in the heart that seem protective against MI, and causes vasodilation, adipose tissue, and skeletal muscle, which improves insulin sensitivity and has other metabolic effects beyond glucose. And we'll talk a little more about effects on the kidneys too. So GLP-1 has a couple of big problems as a drug. One is it's a little peptide, so if you just put it in the stomach, it gets degraded by acid, so it's hard to give orally. And the other one is this half-life of 2 minutes, not very useful for supplementing. So there are a number of drugs. They're classified roughly as short-acting and long-acting. The short-acting drugs are mimics of exendin 4, which is found in the saliva of the Gila monster. And it has a lot of homology to GLP-1 and activates the GLP-1 receptor. And it has alterations at this splice end that make it more resistant to DPP4. And so these have longer half-lives on the order of 2 to 3 hours. These are drugs based on exendin 4, exenatide, and lixisenatide. They do then end up being cleared by the kidney. So they're not proteolytically cleaved, they're filtered and reabsorbed into tubules and destroyed there. So these are affected by low eGFR. Then there are a number of long-acting GLP-1 receptor agonists, and the clinical, the medicinal chemistry of these is absolutely fascinating, actually. So Liraglutide, what it does is it adds a fatty acid midway through the peptide chain here, and this allows it to non-covalently bind to albumin as it floats around, and that sequesters it from activity by DPP4 and increases the half-life to about 12 hours. This is administered daily. And semaglutide down here does the same thing. It has this fatty acid that makes it bind non-covalently to albumin, and it also has a peptide alteration that makes it resistant to DPP4. So this has a half-life of about a week and is administered weekly and is degraded through proteolytic cleavage. So it's not affected by kidney function again. And then these other two molecules, albiglutide is actually covalently bound to recombinant human albumin. And again, for the same reason, has a long half-life. And dulaglutide is covalently bound to the Fc domain of an IgG4, which makes it larger and less susceptible to degradation. These are the formulations available. I'm most familiar with semaglutide, which is what the VA has now up here in the left. It comes in pens. You can kind of dial in your dose, and each of these pens has, depending on your dose, enough for 2 to 6 weeks. And you get little injectable needles that are replaceable that you put on for each weekly dose. These are pictures of liraglutide and dulaglutide down here as well. And there are a number of doses available. The exenatide, again, has to be concerned about renal dosing, but the other GLP-1 receptor agonists don't have dosage adjustments needed. There, of course, is little data in severe chronic kidney disease. All of them are potent at lowering glucose. The long-acting ones are more potent. This is a summary of many trials that have been done in the area. And the long-acting GLP-1 receptor agonists in particular lower hemoglobin A1C by 1 to 2%. They also induce weight loss, and this was observed in the initial trials of type 2 diabetes, but as you know, now there are indications even outside of type 2 diabetes, and this is one of the landmark trials showing weight loss with these drugs. It enrolled almost 2,000 people without diabetes, but who were obese, or had a BMI of 27 or more and one weight-related condition. That could be hypertension, dyslipidemia, sleep apnea, or cardiovascular disease. And they used a dose of semaglutide that's higher than used for glycemic control. Glycemic control is usually half or 1 milligram weekly. This is 2.4, and watched people for 68 weeks. And they lost a lot of weight progressively over a year. And how much weight? About 12.7 kilograms on average compared to placebo, or 12.4% of their body weight. So very effective, at least while you're on the drug. This trial did not have a washout with, and regain could certainly be expected. The main side effects are nausea and vomiting due to this delayed gastric emptying, typically mild and actually go away over time. There's sort of a tachyphylaxis response to that part of the drug effect. And only about 5% discontinued the study drug. We're going to keep hearing more about these. In particular, there are now combined GLP-1 receptor agonists and GIP agonists. The one that's going to be out very soon is tirzepatide, shown here on the upper right. It's based on exendin 4 with alterations of the cleavage site and also fatty acid binding to albumin. And it was just compared head-to-head to semaglutide, and actually had greater hemoglobin A1C lowering compared to semaglutide, and greater weight loss. It's a very powerful drug, and it's being reviewed by the FDA now, and ongoing cardiovascular safety trials are going. So we do have a lot of data about these drugs from cardiovascular safety trials. Listed here, and things I want to point out, this is from the KDIGO guideline. Several of the trials did include people with stage 4 CKD, leader of liraglutide, rewind of dulaglutide, and sustain 6 with semaglutide included any EGFR, just not people treated with dialysis. And in general, the short-acting GLP-1 receptors have had neutral effects on cardiovascular disease, but the long-acting ones have shown benefits. And the KDIGO meta-analysis is consistent with other meta-analyses showing about a 15% reduction in atherosclerotic cardio events with a GLP-1 versus placebo. And that's consistent across EGFR range. So we're shown here in the lower subgroups with EGFR less than 60, and that benefit is preserved. The kidney effects are a little less clear. These drugs do reduce albuminuria, and most of the trials have looked at composites that include incident macroalbuminuria as well as GFR loss, and sometimes show benefit. Right now, what's really missing in terms of kidney effects are dedicated kidney trials of kidney populations with kidney outcomes like credence or DAPA CKD. There is one ongoing, that's the FLOW trial, and clear evidence of the effect on GFR loss. Just recently, a publication was EPUB'd. It was a combined analysis of two of the large trials, leader of Liraglutide and SUSTAIN 6 of semaglutide. So together, 12,000 people followed for a relatively short period of time for a kidney trial. Combining these drugs, they reduced albuminuria versus placebo by 24% and slowed the slope of eGFR loss by magnitude shown here. When they looked at kind of the traditional time to GFR loss outcome, it varied by how you define GFR loss. So looking at persistent 30% reduction, there's no significant effect. Looking at 40 or 50% persistent reductions or kidney failure, 14 or 20% effects that were significant, and doubling of serum creatinine, 11%. So really kind of equivocal findings, but certainly a suggestion that there's a benefit on time to eGFR loss. That benefit seemed to be larger in people who had stage 3 CKD of the eGFR of 30 to less than 60. And that's also a population that's been studied in Kathy Tuttle's trial, Award 7, which was, she's presented these data before too, people with type 2 diabetes and eGFR 15 to 59, 600 people. And they were assigned to either Dulaglutide once a week plus aspart insulin or Glargine plus aspart insulin. This was a unblinded study, but it was an active control, and glycemic control was similar between the two groups. And albuminuria was reduced with Dulaglutide versus Glargine. Weight was lower by 3 or 4 kilograms. And there was a suggestion that compared to the insulin group here in the blue squares, that those assigned to Dulaglutide had a lower slope of eGFR loss over the 1-year duration of the trial. It's quantified here in the middle. And fewer events of 40% decline in kidney function or end-stage kidney disease, though the number of events was low. There's also provocative observational data on these drugs, and pharmacoepidemiology is always controversial. I'm a fan of well-conducted pharmacoepidemiology. I think that it helps us evaluate wider populations that are more generalizable than the trials. More real-world application, sometimes larger numbers of people and events. And when done well, as this one was, I think can really add to the clinical trials data, even if they're still potentially confounding. This study used data from Stockholm, who newly initiated a GLP-1 receptor agonist or a DPP-4 inhibitor. So it used some very nice design elements for these type of studies. It was restricted to people who had an indication for the drug, type 2 diabetes. It looked at new users to eliminate a prevalent user bias, and it used an active comparator. And doing that, it suggested that GLP-1 receptor agonists reduced a kidney composite outcome, which was doubling of serum creatinine, kidney failure, or death by about 28%. And atherosclerotic events by 15%, which is exactly the same as the meta-analyses have shown. So again, more suggestive evidence, certainly not definitive, but more suggestive evidence that these drugs have kidney benefit. How do they have kidney benefit? I'll say that when I started putting this together, this talk together, I thought I was planning to do a deep dive on mechanism. And I aborted that because I have to say that I can't really find convincing stories to say exactly what the effects are of GLP-1 on the kidney. I actually think this is an area where new research is certainly needed, where things like organoids, kidney on a chip, and single-cell RNA-seq studies could really help advance the field. There's a lot of opportunity here. So we do know that GLP-1 receptor agonists or receptors, excuse me, are present in the glomerular vasculature, arterioles, and proximal tubular cells. Shown here on the bottom is an immune stain of GLP-1 receptor in nephrectomy controls. On the left, early diabetic nephropathy, where there's increased protein in the glomeruli and in proximal tubules, and then in advanced diabetic nephropathy, where the protein is less abundant in all of these locations. So it seems to vary on disease stage. And there is conflicting data on this. There seem to be differences in stains, in antibodies used for these stains. Even single-cell RNA-seq data is conflicting and inconsistent, may relate to differences across disease presentation and disease stage. One thing that we do know is that GLP-1 does act on the proximal tubule to inhibit the sodium hydrogen exchanger NH3, shown here in this complicated diagram on the right, and that does lead to some natriuresis. And that's been confirmed in physiology studies in humans, though it seems to go away after a period of weeks, either because there are compensatory responses or other reasons. There are complex effects on intrarenal hemodynamics. GLP-1 seems to affect nitric oxide, endothelin, as well as the intrarenal RAS system, but these effects are inconsistent across various studies and hard to explain. Putting all these together, along with the indirect effects on glucose, lipids, et cetera, there are a lot of potential mechanisms, and in animal models, at least, these seem to be beneficial. And there's reduced inflammation, oxidative stress, stimulation of mitochondrial function, and autophagy that all seem to be good for the kidney, and how that plays out in humans in some needs to fully be explained. So back to my cases, what about my transplant patient? I did bring this up with him. We also talked about SGLT2 inhibitors, though I remain a little reluctant to prescribe SGLT2 inhibitors to immunosuppressed transplant patients with general mycotic infection risk, et cetera. And this patient, we talked about both. He was very eager to try the GLP-1 receptor agonist. He was fond of the idea of a shot rather than more pills. He'd taken darbepoetin and testosterone shots before, given those to himself, so this was not new to him. He was excited about the prospect of weight loss and wanted to really get this hemoglobin A1C under control. And at the VA, I was able to just send him to the pharmacy. He picked up his first couple of pens, and the nurses showed him how to use the pens and administer the shot that day in clinic. And he's off to the races, and we'll see how he tolerates it. Is there evidence to support this approach in transplant patients? No, I could only find case reports in transplant patients. So we're really extrapolating from the studies that I've shown. There are lots of review articles on the topic, and it's attractive theoretically for a number of reasons. And if we think about the concept of post-transplant diabetes mellitus, it's caused by a number of factors. One is insulin resistance related to obesity and some of the effects of prednisone and other things on insulin action. GLP-1 may help mitigate that a little bit with its weight loss. Probably the biggest driver of post-transplant diabetes is loss of beta cells, and that's related in part to toxicity from calcineurin inhibitors and others on those beta cells. And theoretically, at least the pro-beta cell actions of GLP-1 could help beta cell survival. And then, of course, if there are beneficial effects on heart, which we've seen, and possibly kidney, those are also desirable for this population. So reasons to suspect it might be beneficial, it fit into this person's lifestyle and seemed like a good choice. What about the dialysis patient? This is really an evidence-free zone. There are some small trials in hemodialysis patients, which are really not very contributory. Peritoneal dialysis is a whole nother can of worms in that GLP-1 receptor agonists stimulate glucose mediated insulin release. Peritoneal dialysis patients, unlike most of us, are getting glucose intake all the time from their peritoneal dialysate, and so they're always postprandial. And how GLP-1 receptor agonists work in that setting is completely unknown. So I have to admit that. And then also of course, they have a big belly full of fluid, and that plus delayed gastric emptying can increase side effects. Nonetheless, this patient wanted to give it a shot. He didn't want to do more insulin, and I was concerned that just once daily glargine insulin was not going to cut it for him, that he may have to go to prandial insulin. So he wanted to give this a shot. We started a very low dose, 0.25 milligrams a day, which he tolerated for about a month, and then he developed some GERD, which I think might have been related to the drug, easily controlled with a PPI. And so far, he wants to keep going. He's actually been able to go off, not off, down on his insulin. He's on 30 units a day now, and his blood glucose is much better on this low dose of semaglutide. And so we'll see how it goes. But I think this is really almost experimental use of the drug, but may work for him. Many of you know that these are expensive drugs. This is from the ADA Standards of Care issued last month. And the average monthly cost is shown here in the red box. It's $800 or $900 a month. This is more expensive than SGLT2 inhibitors or DPP4 inhibitors. It's 2 orders of magnitude higher than metformin or sulfonylureas. So that certainly is a consideration. I do have just one little bit of data that I'll share before closing here. And this is a nice study from Christine and Leela and others looking at use of these medications in the United States population, not specific to chronic kidney disease, but this is NHANES data looking over time at people with type 2 diabetes who have eGFR of 30 or more and their medication use. And about 2/3 of people with type 2 diabetes in the US are using metformin. That's appropriate, long recommended first-line therapy, inexpensive. About 20% of people are using insulin, about 20% using sulfonylureas. That's been fairly stable over time as well. Obviously, people can be using more than one of each of these agents. DPP4 inhibitors, despite no real outcome benefits and substantial cost, remain the next highest prescribed drug, about 12%, and actually going up over time. You can see SGLT2 inhibitors, which started in 2014, were not used then, now used in about 6.5% of people across the United States, but picking up steam. GLP-1 receptor agonists, despite quite a bit of data, and maybe because in part of their cost, been relatively steady in their use over time at about 4.5% of patients. And there are differences in who's getting these, as you might expect. Less use in older adults, some differences by self-reported race, ethnicity, less use of GLP-1 receptor agonists in uninsured patients, and not much use in our CKD patients. So conclusion about these drugs, they are recommended for many patients with type 2 diabetes. They're very effective for glucose lowering. They lead to weight loss and reduced CVD events that are possible, or maybe I think we're getting more and more data that you might say probable kidney benefits. They can often be used when other meds can't. So when eGFR is less than those acceptable for metformin or SGLT2 inhibitors. And I think post-transplant is actually probably a particularly good use for them. Dialysis, I think, is more questionable. And there are many implementation barriers, including cost and inequity. So I'll stop there. I'm not sure if there are time for comments and questions, Matt.
Sure, yeah, time for a couple of questions, comments. Looks like there's one in the chat. Are you actively taking patients off sulfonylureas to get them on SGLT2 inhibitors or GLP-1 agonists?
Hi, Wei Ling. Yeah, thanks. I am actively taking people off sulfonylureas to put them on SGLT2 inhibitors, yes. I've not done that for GLP-1. I'm just getting started with GLP-1 receptor agonists. That's part of my interest here. I do think that as we have more options for treatment of people with diabetes and CKD, that it would be good for all of us to become more familiar with all these drugs. I think this is a good option for many of our patients. And I think we should be asking the sort of questions that you just asked. But yeah, thank you.
Maybe I'll ask one last question, Ian. So, I think we had this symposium last year about SGLT2 inhibitors where I think we were sort of talking about the various interdisciplinary communication issues that have to occur with SGLT2 inhibitors. And we asked the question, are SGLT2 inhibitors nephrology medications or are they not? And I think we all have an answer to that now. They are. So what is your answer about GLP-1 receptor agonists? Are these nephrology medications or are they not?
Yeah, great question, Matt. And I agree with your SGLT2 in conclusion. And part of that is because they're pretty modest drugs for glycemic control. GLP-1 receptor agonists are different. The flow trial may change things if we see profound kidney effects. They're mainly glycemic drugs. The KDIGO guidelines recommend them mainly for glycemia. And you do have to be careful when you're adding one about co-management of other glucose-lowering drugs. So I think they're primarily glucose-lowering drugs, but they do have all of these other benefits. And so understanding, as Wei Ling asked, how we may want to adjust the medications to fit them in is valuable. And I'm doing this on limited patients myself. More often, I'm working with primary care docs, endocrinologists, saying, "Hey, I think we should do this. What do you think?" And I think that's probably most commonly the right approach at this point.
All right. Well, thanks so much. That concludes the Diabetic Kidney Disease Power Hour.